Welcome to the Deep Dive. Today we're taking on what is really the most essential anatomical knowledge, the absolute foundation you need for any kind of clinical practice.
And we're distilling it directly from a really targeted source, excerpts from BRS Gross Anatomy.
Exactly. And our mission isn't just to list the facts, but to look at how these expert sources actually structure information so you can learn it efficiently.
That's such a critical point. When you're faced with a mountain of information like gross anatomy, the structure of the material itself is, it's almost as important as the content.
Right.
And this source gets that. It starts from the premise that anatomy is the language of medicine and surgery. So the approach is to give you a solid backbone first, a quick overview of systemic anatomy.
So that's your skeletal, muscular, nervous systems, that kind of thing.
It's a big picture, but then, and this is the important part, it pivots.
Pivots fast. I really appreciate that clinical relevance.
It pivots to regional and clinical anatomy. So you're immediately looking at the back, the thorax, abdomen, limbs, head, and neck.
Because that's how patients present. They don't come in saying, my systemic nervous system hurts.
Exactly. You treat a region, you operate in a region. It mimics the reality of the hospital floor.
The structure itself is fascinating to me. It's not just a textbook. It feels more like a training tool.
Mm-hmm.
So how does it really maximize retention for someone, say, studying for boards?
Well, the whole goal is high-yield retention. It does that with a few key features. For instance, the visuals. They're not all the same. You have these simple schematic drawings for core concepts.
Just the basics.
Right. And then you have more complex illustrations that show the really crucial anatomical relationships. The what's next to what that a surgeon absolutely has to know. Then there are the tables of muscles.
Oh, those tables are lifesavers for a quick review. But where does it really build that bridge between, the anatomy lab and the actual clinic?
That happens in the expanded and updated clinical correlations. They're set apart in these little boxes so they really grab your attention.
To stand out.
And they don't just state a fact. They show you why that fact matters by linking a basic structure directly to medical practice. So as you're reading about a nerve pathway, you instantly see why knowing that pathway is critical.
Gives you this so what? You're not just learning anatomy, you're kind of learning differential diagnosis at the same time.
Precisely. And then for review, you have the high-yield topics with end-of-chapter summaries. This is just zeroing in on the most frequently tested material.
The stuff you know is coming.
Exactly. It forces you to connect the dots between anatomical structure and common clinical problems. It's about problem solving, not just memorization. And then, of course, it all ends with a comprehensive examination.
A full self-assessment.
Yeah, to find your weak spots before the real test.
It's an architecture that's built for success. Okay, let's unpack some of this foundational knowledge now, starting with those core systems, the building blocks.
Let's start with the physical engine. The muscular system. The basics are, skeletal muscle is voluntary, it's striated, and it's about 40% of our body mass.
And its job is pretty straightforward. Movement, posture, generating heat.
Right. But here's a crucial detail for any anatomical description. Every muscle has an origin and an insertion. The origin is the more fixed or proximal point. It stays put. The insertion is the part that moves.
That's such a key distinction to get right from the start. Okay, so from physical movement to the control center, let's talk about the nervous system, which can be incredibly complex.
You have to categorize it immediately. First, the central nervous system, or CNS, that's simple, the brain and spinal cord. The command center.
And everything else.
Is the peripheral nervous system, or PNS. That's your 12 pairs of cranial nerves, 31 pairs of spinal nerves, and all their associated bits. Functionally, we split that again into somatic and visceral, or autonomic.
And before we go any further, we have to nail down two terms that trip up almost everyone at the beginning. The names for collections of cell bodies.
Yes, this is fundamental. A ganglion is a collection of neuron cell bodies outside the CNS. Think peripheral. A nucleus, on the other hand, is a collection of neuron cell bodies inside the CNS.
Location, location, location.
Got it.
Just keep those two separate and you'll avoid a lot of confusion.
Okay, and then we get to that alphabet soup of the 4 general nerve fiber types. It sounds intimidating.
It does, but let's just simplify it by direction and target. We use S for somatic, which means body wall, and V for visceral, meaning organs. Then A for afferent think ariding or sensory, and E for efferent think exiting or motor.
Okay, that framework helps, so let's try it.
Okay, sensation from the body. Pain, temperature, touch. That's coming from the body, so it's general somatic afferent, GSA.
And the motor command going to the skeletal muscles to make them move?
That's general somatic efferent, GSE. Motor impulses out to skeletal muscles.
So that's our voluntary system covered. Now for the involuntary stuff, the visceral.
Right. Sensory info from your organs, like your stomach feeling stretched, is carried by general visceral afferent GVA fibers.
And the motor commands that control your heart rate or make your gut move. That's the general visceral efferent GVE system. Those are your autonomic nerves, hitting smooth muscle, cardiac muscle, and glands.
And that GVE system, the autonomics, it provides such a perfect clinical contrast, especially when you look at something like the GI tract.
It's the ultimate example of dual control. When your sympathetic GVE fibers are active, your fight or flight, they inhibit motility in the gut and constrict the sphincters. Things shut down.
But the parasympathetic,
The rest and digest system, it does the exact opposite. It stimulates motility and secretion, and it relaxes those sphincters so digestion can happen. You have to understand that push-pull relationship.
okay, this is where it gets really interesting for me. Connecting these functional basics to the regions where things actually go wrong. Let's start with the back and spine. So much trauma, so much chronic pain.
The spine is an engineering marvel, but it's vulnerable. And the intervertebral discs are central to that. You just have to remember there are two parts. The soft, gel-like center, the nucleus pulposus.
Which is a remnant from the embryo, right?
There we
From the
go.
notochord.
Exactly. And that's surrounded by a tough fibrous ring, the annulus fibrosus.
And the high-yield pathology here is obviously the herniated disc.
Yes. A herniated disc is when that nucleus pulposus pushes out through the annulus, and because a ligament in the back is a bit weaker on the sides, it almost always happens posterolaterally.
And it hits the nerve root just below it. So a classic board question would be,
The most common level is L4, L5. That's the one to remember,
which leads directly to that classic radiating leg pain.
which is sciatica. That's the definition. Pain, maybe tingling or weakness, starting in the lower back and shooting down the leg, usually because that L4 or L5 nerve root is being compressed.
And on the much more traumatic end of the spectrum,
We have to mention the hangman fracture, a fracture through the pedicles of C2, the axis. It's often fatal because the forces involved can tear the ligaments, holding everything stable, leading to a catastrophic crush of the spinal cord.
let's move up into the thorax. Let's focus on the cardiopulmonary system, where anatomy dictates some really predictable risks.
Absolutely. When it comes to the airways, the anatomy of the main bronchi is critical. You have to picture it. The right primary bronchus is shorter, it's wider, and it runs more vertically than the left one.
So if you aspirate something,
When you aspirate a foreign body, a peanut, whatever, it's almost guaranteed to end up in the right primary bronchus or one of its lower branches. It's just the path of least resistance.
that's a huge clinical point.
Hmm.
And with the heart, let's just quickly confirm its blood supply.
Simple and vital. The coronary arteries, which feed the heart muscle itself, come directly off the ascending aorta, right at its base.
And speaking of the heart, one of the classic congenital defects you have to know is the tetralogy of Fallot.
Right, it's a combination of 4 specific structural problems.
Can we list them out, just to be sure?
Of course. First, you have pulmonary stenosis, which is a narrowing of the outflow to the lungs. Second, an overriding aorta, where the aorta is kind of sitting over both ventricles.
Instead of just the left.
Correct. Third, a ventricular septal defect, or VSD, which is a hole between the ventricles. And fourth, as a result of all that, you get right ventricular hypertrophy because the right ventricle is working so hard.
And that combination causes a right-to-left shunt bypassing the lungs, which is why you see cyanosis, the bluish skin.
That's the classic presentation.
Okay, shifting down to the abdomen, let's look at the liver and the adrenal glands. 2 amazing examples of multifunction in embryology.
The liver is, it's the body's main chemical plant. It's staggering. It produces bile, detoxifies blood, stores glycogen, synthesizes plasma proteins.
Its clotting factors and anti-clotting factors.
Fibrinogen, prothrombin, and heparin. It manages basically everything coming from your digestive tract.
And the adrenal glands sitting on top of the kidneys, they have that incredible dual origin story.
They really do. The outer layer, the adrenal cortex, is essential to life. It makes steroid hormones, but the inner part, the adrenal medulla, develops from neural crest cells. It's essentially a modified sympathetic ganglion.
Which explains its unique innervation.
It's why the medulla gets direct preganglionic sympathetic fibers. It gets the signal and boom secretes epinephrine and norepinephrine right into the bloodstream for that instant fight or flight response.
That's fascinating.
Hmm.
Moving down into the pelvis, the prostate is such a high-yield area where the specific lobe dictates the pathology.
This is critical diagnostic knowledge. The middle lobe of the prostate is where you typically see benign prostatic hypertrophy, or BPH. That's the non-cancerous enlargement that blocks the urethra.
Causing all the urinary problems.
Yes. But, crucially, the posterior lobe is the area most prone to becoming cancerous.
And when it does become cancer, what's its preferred route for metastasis?
It loves to go to bone pelvis, vertebrae, skull, and it gets there via the vertebral venous plexus. This is a network of veins without valves, so cancer cells can travel easily up the spinal column.
And just to round out the pelvis, in females, the muscular floor.
The levator ani muscle. Innervated by S3 and S4, it's the dynamic floor of the pelvis, providing absolutely critical support.
All right, let's finish up in the head and neck, focusing on those cranial nerves, because understanding the deficit tells you exactly which nerve is damaged.
Absolutely. A patient walks in with sudden one-sided facial weakness. You're immediately thinking about the facial nerve, CNE7.
And the diagnosis is Bell palsy. What are the key signs?
You see a loss of forehead wrinkles on that side, the eyebrow droops, they can't fully close their eye, and they lose taste on the front 2/3 of the tongue. That total involvement is key.
And then there's the oculomotor nerve, CN3, which gives you that classic down and out gaze.
Yes, it supplies most of the eye muscles, so a lesion causes a ptosis, an eyelid droop, and the eye rests down and out. But it also carries parasympathetics.
Ah, so that affects the pupil.
It causes a dilated pupil and a loss of the pupillary light reflex.
Finally, let's talk about the laryngeal nerves. They're so vulnerable during neck surgery, like a thyroidectomy.
Very vulnerable. They're branches of the vagus nerve. The recurrent laryngeal nerve has that infamous looping path around the subclavian artery on the right and the aortic arch on the left.
So damage there.
Damage there causes hoarseness, maybe a total inability to speak because it paralyzes the vocal cord.
And what about the other one? The one people sometimes forget.
The external laryngeal nerve. It travels with the superior thyroid artery, so it's right in the surgical field. Damaging this one knocks out the cricothyroid muscle.
Which tenses the vocal cords.
Exactly. So you can't produce high-pitched sounds, your voice gets weak and tires easily.
And to wrap up, one final eye pathology that's all about fluid dynamics.
We have to mention glaucoma. It's all about high pressure inside the eye. That pressure builds up because of a plumbing problem, impaired drainage of aqueous humor.
Fluid can't get out.
Right. It's produced by the ciliary processes, but its exit, the sclerovenous sinus or Schlemm's canal, is blocked. That pressure damages the retina and can cause blindness. It's a mechanical problem.
So what does this all mean for you, the listener? We've seen that anatomy isn't just about lists. It's about integrating the architecture, from prostate lobes that guide cancer screening to the angle of a bronchus that predicts aspiration risk.
It means every fact we've talked about, whether it's the embryology of the adrenal gland or the L4-L5 disc space, is a high-stakes clinical detail. The source material gives you the map, but it's your job to connect these structures to what happens to real patients.
That integration is the whole game. Now, for our review exercise, let's go back to the neck. This will test your ability to differentiate those vulnerable structures.
Okay, here's the scenario. A surgeon is operating and needs to tie off the superior thyroid artery. What nerve traveling right alongside it is at risk, and what specific voice function would be lost if it were damaged?
And as a part two, think about a different related nerve. How might a patient with a large tumor pressing on their aortic arch present in terms of their voice?
Think about tension versus hoarseness and those very different looping paths.
The success of your learning really depends on making these connections, so keep exploring them. For instance, think about this. What other systemic features drive regional pathologies? We talked about the vertebral venous plexus for prostate cancer. How might that differ from, say, the portal venous system when you're thinking about how GI cancers spread? That's the kind of comparative thinking that builds true expertise.